So already you are continuing about the different types of the antibiotics, that is the antimicrobial agents, and you have also read about antiprotozoal drugs. You are on the course of the antifungal drugs, antimalarial drugs. You will read about the antihelminthic drugs, similarly antiviral drugs. So those drugs which are effective against a virus. Now what is virus? Virus is basically intracellular obligate parasite. So basically they are dwindling between a living and non-living object. They need our own machinery, that is the host machinery, for their survival, for their multiplication. It is just a DNA or RNA, that is the genetic material that is cased by a protein. Around this there may be some envelope, and this virus ultimately attaches and enters within the host cells and uses the host cell machinery for its multiplication. So that's why it is difficult to kill the virus. So when we want to develop antiviral drugs, that drugs can also harm our own cells, because these virus cells usually need our host machinery for their multiplication, for their metabolism, for their survival. That's why if we are using some antiviral drug, that can also affect our host cells. So the number of the antiviral drugs are less. Antiviral drug discovery is also in a lower pace in comparison to the other antibacterial agents. Nevertheless, newer and newer drugs and newer targets are being identified so that the drugs can attack with those targets and the host cells will be spared, so that there will be less adverse effect and more efficacy of these antiviral drugs. So viruses are small, usually in the range of 20 to 30 nanometer, that is, this is very small, smaller in comparison to the bacteria. And their cells are also simple. It is not complex like that of the bacterial cells or the fungal cells. They are incapable of reproduction outside their host cells. So for their reproduction, for their multiplication, it needs the host cell machinery. The free living virus particle is termed a virion. Virion is outside the host cells and consists of segments of the nucleic acid, that is either it is DNA or RNA. So there are different types of the DNA viruses, for example herpes virus, pox virus, and there are different types of the RNA viruses like influenza virus. So this genetic material is present within the cells and there is case, simple structure of the virus. So it is enclosed in a protein coat, this DNA and RNA comprised of symmetrical repeating structural units, and this is known as the capsid. So there may be some envelope outside of the capsid is also may be there. The viral coat together with the nucleic acid coat is called the nucleocapsid. Viral coat with the nucleic acid coat. This is known as the nucleocapsid. Some viruses apart from this may have some lipoprotein envelope outside of their capsid also. Certain viruses also contain some enzymes that initiate their replication in the host cells. So this is the enzymes that ultimately dictates that if we are targeting these enzymes that is not present in the host cells, then the side effects or adverse effects may be less. Now coming to the viral replication. So we are using drugs that basically blocks the viral replication. There are different types of the antibacterial agents that basically kills the bacteria, but usually we cannot kill the virus. We are basically stopping their multiplication. Okay. So replication of the DNA viruses basically starts with the entering of these viruses within the host cells, where transcription into mRNA occurs, which is catalyzed by the host cell RNA polymerase, and translation of the mRNA into virus specific proteins then takes place. So it enters within the cells, then transcription of the protein happens, and then it is enclosed within this, and then translation happens, transcription, translation. Some of these proteins are enzymes that then synthesize more viral DNA. More and more viral DNA are getting synthesized, as well as the structural proteins that comprising the viral coat and envelope. So this viral coat, viral envelope, capsid, all these are the proteins. So protein are basically developed from the transcription and then translation. And after assembly of these coat proteins around the viral DNA, complete virions are released by budding or after host cell lysis. So the virus, now it needs the multiplication. So ultimately there will be either budding or the host cell lysis, destruction of the host cells, and more virions are powered into the outside. Similarly, the replication of the RNA virus happens. Enzymes within the virion synthesize its mRNA from the viral RNA template. So there is virus, there is RNA, and there is template is also there, and from this template newer and newer RNAs are formed. Viral RNA serves as its own mRNA. So you know from the transcription it needs a mRNA, and accordingly a newer genetic material will be formed. Similarly, in case of the RNA virus, its own RNA acts as an mRNA so that newer and newer genetic materials are formed. This is translated by the host cells into various enzymes, including RNA polymerase. So in the DNA, important enzyme is the DNA polymerase. Here the RNA polymerase is there. And also different types of the structural proteins of the virions. So ultimately virion, that is the outside, the viral particles, needs different types of the proteins, and that are synthesized within the host cell machinery. And then the assembly of these virion particles happens, and then release of the virions happens. So host cell nucleus is usually not involved in replication of the RNA viruses, and although some like some ophthalmic replicate exclusively within the host nuclear compartment. So more or less you can say that without the host cell, without the host cell machinery, without the enzymes of the host cell, the virus cannot be completed, the virus cannot replicate, the virus cannot multiply. So if we are targeting these areas where it needs some polymerization, DNA polymerase or RNA polymerase, or where it needs some assembly or uncoating of the viruses, or where it needs to release from the host cell to the outside, if we are targeting these areas so that we can block the multiplication of the viruses. So this is the basis of the action of different antiviral drugs. So you can see, so this is the host cells. So virus particle comes, and within the chromosomes you can this is the cell membrane, they attaches. After the attachment there will be transcription and translation. More and more virion particles are formed. These virion particles are assembled, uncoating happens, and then again it is released. So we can target different areas. This 1, 2, 3, 4, 5. 1 means attachment to the host cells. So we can target here so that it cannot attaches with the host cells. So we can target about the uncoating of the virus and entry of the viral nucleic acid into the host cell nucleus. This point number 2, we can target this. We can target the control of the DNA, RNA and protein production, that is different areas of the transcription and translation, DNA polymerase, RNA polymerase. Then the production of the viral subunits, we can target here. We can target about the assembly of the virions, the point number 5, assembly, and then release of the virions. So we can target in different areas of the viral multiplication. So viral multiplication cannot happen if there is no host cells. So outside of our body, outside of the host cell, virus cannot multiply. Okay. So antiviral drugs need certain characteristics. So it should be able to enter the cells infected with virus. So the drug should be such that those cells which are infected with virus should take up the antiviral drugs, but not those cells which are not infected with the virus. So it should be more specific for the viral infected cells. Interfere with the viral nucleic acid synthesis and or regulation. So the transcription, translation of the different viral nucleic acid, different proteins, this should be interfered with by the antiviral drugs. Some drugs interfere with the ability of virus to bind to the cells, as we already discussed. So binding to the cells, entry of the cells within the virus, this can be inhibited by the antiviral drugs. Some drugs stimulate the body's immune system so that the drugs cannot multiply. Our own immune system can tackle these viruses. Best response to antiviral drugs are in patients with competent immune system. If there is immunocompromised persons, for example, the patients are under cancer chemotherapy, the patients have some HIV/AIDS infection, or the patient is under some immunosuppression drugs, for example, after kidney transplant. So here the patients are already immunocompromised. So these viruses multiplication will be more, an antiviral drug also we need in more doses, or some more drugs are needed to tackle these viruses. A healthy immune system works synergistically with the drug to eliminate or suppress viral activity. Now the classification of the antiviral drug. So first antiviral drug is the Idoxuridine. Idoxuridine is the first antiviral drug that was invented in the 1930s. It was basically against the herpes virus. So previously and also now, herpes virus infection is very common. There are different types of the herpes viruses. Most common is the herpes simplex 1, herpes simplex 2 and varicella zoster virus. These three types of the viruses are more common for infecting us. Herpes simplex virus 1 usually causes infection in the oronasolabial areas, skins, etc. Herpes simplex virus 2 usually causes infection in some genital areas. Varicella zoster virus may cause the zoster infection. So Idoxuridine is the first drugs which have shown to be efficacious against this herpes virus infection. And later different other drugs also came, like Trifluridine, Acyclovir, very commonly used nowadays also, Valacyclovir, which is the congener of the Acyclovir, Famciclovir, Ganciclovir, Valganciclovir, Cidofovir, Foscarnet, Fomivirsen. These are some anti-herpes virus drugs, and newer drugs are also getting invented, also getting discovered, you can say, because there are some drugs which have become resistant. Because the viruses are continuously showing the mutation, newer and newer virus mutations are showing, some drugs are not effective against these viruses, so newer drugs are also invented and discovered. Cytomegalovirus is also a type of the herpes virus, and newer drugs are also getting invented so that it can target the cytomegalovirus, because many drugs are getting resistant to cytomegalovirus. Next, coming to the anti-influenza drug. You know the influenza is also very common, and ultimately that leads to much morbidity and mortality. You know about the Spanish flu. Spanish flu occurs in the 1917-18, and approximately it wipes out 40 to 50% of the world's population. Most deadly virus until now, Spanish flu. And after that, different types of the flu, different types of the influenza virus, due to their mutations come. Like there may be swine flu, there may be avian influenza. So newer drugs are getting invented. Influenza viruses, usually there are two types of the influenza virus type A and type B. There are different drugs like Amantadine, Amantadine, Oseltamivir, Zanamivir, and there are some newer drugs also that are effective against the influenza viruses. So these are the anti-influenza drugs. Next we will read about the anti-hepatitis virus and non-selective antiviral drugs. So primarily for hepatitis B, there may be useful lamivudine, adafovir, dipivoxyl, tenofovir. For hepatitis C, ribavirin, interferon alpha, etc. are very useful. And we will read separately about the antiretroviral drugs which are effective against the HIV/AIDS. So first coming to the anti-herpes virus drugs. Already I have said the herpes simplex virus type 1, type 2, varicella zoster virus, and the last is the cytomegalovirus. These three and also cytomegalovirus, these are quite prevalent in our country and all of the world. Idoxuridine is the first antiviral drug which is the 5-iodo-2-deoxyuridine analog, which basically acts as a thymidine analog. So thymidine is a nucleic acid, so it acts as a thymidine analog. First pyrimidine antimetabolite to be used as antiviral drug. So basically they compete with the thymidine. So thymidine is needed for the viral nucleic acid synthesis. They compete with this, gets incorporated in the DNA, and so that ultimately faulty DNA is synthesized, chain termination happens and viral multiplication will not happen. Okay. But the problem of this first antiviral drug is low viral selectivity. So they can also attaches with the normal host cells, and toxicity, local toxicity is more. Rapid development of the viral resistance also develops. So ultimately the use is restricted to superficial dendritic keratitis, viral keratitis, that is the involvement of the cornea, very common. viral keratitis, mainly those viral keratitis, dendritic viral keratitis or superficial viral keratitis, usually the Idoxuridine drops are now used, and it is more effective than the other types of the Acyclovir ointment. So ultimately the use is restricted to superficial dendritic keratitis, and it is more effective than the what I am saying about the Acyclovir ointment. Usually the Acyclovir ointment is needed, but the Acyclovir, we will read about this, it enters more in the stroma of the eye. So if there is the keratitis involved, there is more stromal involvement, more interior involvement, the Idoxuridine eye drop cannot tackle this. So we need the Acyclovir. Next, coming to the Trifluridine. Trifluridine is next to Idoxuridine. It is a fluorinated nucleoside which acts in the same way like that of the Idoxuridine. It is active against the herpes simplex virus 1, 2, Cytomegalovirus and related ones. Its viral selectivity is also low but somewhat better than the previous ones. DNA synthesis of the host cells is also affected. In India, Trifluridine eye drop is also approved for use in herpes simplex keratitis like that of the previous ones. Higher efficacy than Idoxuridine eye drop is reported, but there may be some ocular irritation and lid edema. So remember, this Idoxuridine and Trifluridine mainly used in superficial viral keratitis as eye drop as of now. Now coming to the Acyclovir. Acyclovir is very commonly used in different types of the herpes infection. It can be used orally, it can be used topically, it can be used intravenously. Okay. It is most efficacious against the herpes simplex type 1, somewhat less against the herpes simplex type 2 and more less against the cytomegalovirus infection. Now this is a deoxyguanosine analog. Antiviral drug usually requires some viral specific enzyme. So this is basically, you can say this is a prodrug which usually need a viral specific enzyme for its activation. Also ultimately this dictates the specificity of this drug against only those cells which are infected with virus. So normal host cells usually do not have the viral specific kinase. So normal host cells are usually spared. Approximately 300 to 400 times more activity is seen for this Acyclovir against the virus infected cells in comparison to the normal host cells. So ultimately that dictates low toxicity for the host cells. That's why it can be given intravenously, it can be given oral. It is preferentially taken up by the virus infected cells, as I have already discussed, because of the selective generation of the active inhibitor in the virus infected cells and its greater inhibitory effect on the viral DNA synthesis. So already we have discussed HSV1 more active against the HSV2, more active against the varicella zoster virus, Epstein-Barr virus. Okay. So how it is activated? So this is a deoxyguanosine analog. Basically it needs phosphorylation for its activation. Now this phosphorylation, the first step of the phosphorylation happens due to the presence of the herpes virus specific thymidine kinase. So the Acyclovir, which is a product, is converted to Acyclovir monophosphate. So in the normal cells, if there is no thymidine kinase, herpes specific thymidine kinase, it cannot be converted to the Acyclovir monophosphate. That's why the toxicity to the normal cells is less. And this Acyclovir monophosphate, then it utilizes our normal host cell kinases. This cellular kinases means our kinases, host cell kinases, to convert to the active form Acyclovir triphosphate. And this Acyclovir triphosphate basically acts by two mechanisms. On the one hand, it inhibits the herpes virus DNA polymerase competitively. In the previous ones, I have discussed that DNA polymerase, because it is a DNA virus, it is needed for the transcription, translation and ultimately release of the more and more variants. So basically they inhibits and interfere with the DNA polymerase. And on the other hand, it gets incorporated in the viral DNA. So ultimately it becomes a faulty ones, the code, the genetic code becomes faulty ones and ultimately it stops the lengthening of the DNA strands. So early termination of the lengthening, translation will be terminated. The terminated DNA ultimately inhibits the DNA polymerase also irreversibly. That is, in other way around, it also blocks the DNA polymerase. Okay. So it is clear. So how the Acyclovir acts? It is a deoxyguanosine analog. Acyclovir is a deoxyguanosine analog. It needs phosphorylation for its activation. It is a product. Acyclovir is a product. And this phosphorylation mainly needs two steps. The first step needs the herpes virus specific thymidine kinase. Without this, it cannot be phosphorylated. So first it is phosphorylated to acyclovir monophosphate, and then it utilizes our host cell phosphorylates different types of the kinases to convert to this active form acyclovir triphosphate that blocks the DNA polymerase, that enters within the DNA, causes the faulty genetic code, premature termination of the lengthening of the DNA, and ultimately the DNA polymerase is blocked, so that multiplication of the virus is blocked. And this acyclovir is most active against the herpes simplex virus type 1, less active against the herpes simplex virus type 2, less active against the varicella zoster virus, Epstein-Barr virus, and Cytomegalovirus. So you can see again the acyclovir, it is converted. You can see this is attaches acyclovir phosphate by means of the viral thymidine kinase. Then by means of the cellular kinases, it is converted to acyclovir triphosphate. Cellular kinase first is diphosphate and then it is converted to triphosphate. In both of these cases, we need the cellular host cell kinases, and then it terminates the viral nucleic acid chain and inhibits the viral DNA polymerase. It is effective both in case of the normal person as well as the immunocompromised person. First one, in genital herpes simplex infection, it is generally caused by the type 2 virus, as I have already said. It can be treated by topical, oral or parenteral acyclovir depending on stage and severity of the disease. So there are different types of the doses schedule are there. For example, 800 milligram, usually 3 times a day for 7 days or 10 days like this. Mucocutaneous herpes simplex, it is mainly caused by the type 1 herpes simplex virus. It can be localized to the lips and gums, usually do specific treatment, but acyclovir skin cream may provide some relief. Deadly one is the herpes simplex encephalitis. So it can infect the brain, and encephalitis can also happen. So here we need the intravenous therapy of the acyclovir for approximately 10 to 20 milligram per kg per 8 hours for greater than 10 days in herpes simplex encephalitis. Again, herpes simplex keratitis can happen, type 1 keratitis. It is acyclovir is equally effective to Idoxuridine, specifically in case of the superficial corneal dendritic ulcer. But if there is more stromal involvement, usually we need acyclovir. Varicella zoster virus, it is less susceptible to acyclovir, higher doses are needed and it should be used only in immunodeficient person. So you know the varicella zoster virus usually may cause the zoster infection. There is some zoster vaccine is also available now. We can also use that. In severe cases, we can use 10 milligram per kg, 8 hourly IV for 7 days. Oral therapy is usually needed 800 milligram 5 times daily is beneficial only if started early. It affords symptomatic relief and faster healing of the lesions. Post-herpetic neuralgia is not prevented, though its duration may be shortened. So in case of the zoster infection, that is after the chicken pox, for a long period of time, this chicken pox viruses, if it is not eliminated, it usually resides within the nerve endings. For example, you have chicken pox in the age of 20 or 25 years. So in the 70 or 80 years, when you will be 70 or 80 years, there will be reactivation of these chickenpox viruses, and that ultimately leads to zoster infection. Usually this zoster infection causes some unilateral rash, and that causes severe itching, severe uncomfortable sensation as well as the pain. So usually it needs the treatment with the acyclovir, but in the high doses like 800 milligram 5 times a day, 5 times a day for approximately 7 days, 5 to 7 days. But it usually does not eliminate the post-herpetic neuralgia. If you can remember, there are different types of the antidepressant drug. During our teaching with the antidepressant drugs, I have said that one of the indication of the antidepressant drug is different types of the neuralgic pains. So post-herpetic neuralgia also needs different types of the antidepressant drugs or different types of the anti-epileptic drugs to decrease this neuralgic pain. For example, we can use the pregabalin. which is one of the drug of choice. We can use the gabapentin, we can use the duloxetine. Okay, so these are the drugs that are needed in association with the acyclovir for the treatment of the postherpetic neuralgia. Okay. Next is chickenpox. Very commonly patients with immunodeficiency and in neonates only cause for specific therapy. Acyclovir 15 mg per kg per day IV 7 days is the drug of choice. Oral acyclovir 400 mg 4 times a day for 7 days given during the incubation period may abort chickenpox in susceptible contacts. Usually now the standard of the practice is, if a patient comes with the chickenpox, we can start with the treatment with the acyclovir. Usually within the 48 hours it decreases the duration of the viral shedding, decreases the illness. So we can use usually 400 to 800 milligram acyclovir 5 times a day for 5 days. Usually this is the standard treatment is needed for the chickenpox. Similar treatment is needed in case of the postherpetic herpes zoster infections. That is that these chickenpox viruses ultimately gives rise to the herpes zoster infections in the long run. Okay. So this is the indications. So you can see these all are the indications of the acyclovir. So what are the adverse drug reactions? When we are using some topical cream of the acyclovir, there may be some stinging and burning sensation, it can happen. Oral, the drug is usually well tolerated, but some gastrointestinal discomfort may happen. Intravenous, there may be some allergy or anaphylaxis can happen, that is characterized by the rashes, sweating, fall in blood pressure. Dose dependent decrease in glomerular filtration rate is the most important toxicity. Mainly it happens if there is already kidney compromise is there for those patients. That is some chronic kidney disease is there. It normalizes on discontinuation of the drug. More or less we can say that acyclovir is very safe drug. The adverse drug reactions is very less. Okay. Next is Valacyclovir. Usually the acyclovir, the bioavailability is very less, approximately 20%. That's why we need very high doses of the acyclovir and frequency, approximately 5 times a day we need it. Valacyclovir is basically a ester prodrug that increases the bioavailability of this acyclovir to approximately 55 to 70%. So when we are attaching some valyl group to this, the bioavailability is increased. So ultimately that needs a lesser dosing, lesser frequency of the dosing due to active transport by peptide transporters in the intestine. Next is Famciclovir. Famciclovir is another ester product of a guanine nucleoside analog. Famciclovir is previously discovered after the acyclovir, and this Famciclovir is an ester product. More better bioavailability, lesser adverse effect, good oral bioavailability and prolonged intracellular half-life of the active triphosphate metabolite. So like acyclovir, it needs the viral thymidine kinase for generation of the active DNA polymerase inhibitor. More or less the action is similar. It inhibits herpes simplex, herpes zoster, but not acyclovir resistant strains. Some activity against the hepatitis B virus has also been noted. Basically, it is used as an alternative to acyclovir for genital or orolabial herpes and herpes zoster. So Famciclovir as well as the Penciclovir, this Valacyclovir, all these are basically used in the same indications like that of the acyclovir in different types of the age group of the patients. Next, coming to the Ganciclovir. Ganciclovir is an analog of the acyclovir which is active against all herpes viruses. That is, it is active against the herpes simplex 1, 2, herpes zoster, Epstein-Barr virus, and it is very effective against the Cytomegalovirus also. Previous ones that we have discussed is very less activity against the Cytomegalovirus, but it has good activity against the Cytomegalovirus. Okay, it is the most active. Due to poor oral absorption, again the valyl group is attached, and Valganciclovir is usually discovered which have higher bioavailability and is preferred wherever available. So Ganciclovir and Valganciclovir mainly used in case of the Cytomegalovirus infections. Systemic toxicity of the Ganciclovir is high. Remember, the acyclovir, the systemic toxicity is less, very less, but here it is high. So bone marrow depression, rash, fever, vomiting, neuropsychiatric disturbances all can happen. So usually the use is restricted to prophylaxis and treatment of severe cytomegalovirus infections. So cytomegalovirus can give rise to the pneumonia, colitis or retinitis. mainly affecting the immunocompromised persons like HIV/AIDS persons, transplant recipients like after renal transplant, kidney transplant patients. So it is clear. So Ganciclovir and Valganciclovir, these are effective against all types of the herpes virus infections, but it is very much toxic. That's why it is mainly reserved only in case of the cytomegalovirus infections, which is not responding to other types of the anti-herpes virus therapy. Now this cytomegalovirus infections is more prevalent in case of the immunocompromised persons. Already we have discussed immunocompromised means if the patient is taking some organ transplant and after this some immunosuppression drugs, if there is anti-cancer chemotherapy, if there is HIV/AIDS. So in those cases there may be some cytomegalovirus keratitis, cytomegalovirus pneumonia, cytomegalovirus colitis can happen. So in these cases we need Ganciclovir or Valganciclovir treatment. So you can see Ganciclovir or Valganciclovir ultimately, which is an analog of the deoxyguanosine, again similar to like that of the Acyclovir, by means of the herpes simplex virus 1 thymidine kinase, it is converted to monophosphate. Again by means of the thymidylate kinase, this is the host ones, it is converted to diphosphate and triphosphate by dinucleotide kinase, and then it ultimately blocks the DNA polymerase, competitive inhibition and termination of the DNA elongation. So the action, the mechanism of action similar to that of the Acyclovir. Next, coming to the Cidofovir, another good drug. It is a monophosphate nucleotide analog of the Cytidine, which inhibits most DNA viruses like herpes simplex virus, cytomegalovirus. Also it inhibits different types of the pox virus and adenovirus also. Okay. So many herpes simplex virus who are resistant to normal therapy and many cytomegalovirus who are resistant to Ganciclovir, they can respond to this Cidofovir. Okay. So mainly it is used in different types of the resistant cases. Again it is a monophosphate, it does not require viral phosphokinase and is converted to the active diphosphate by cellular enzymes. So this is, the mechanism is somewhat different from the previous all of these ones, because it does not usually need the viral specific thymidine kinase. Normal cellular kinases usually convert it to its active form. So mainly it is used in cytomegalovirus keratitis in HIV/AIDS patients, particularly those who have failed the Ganciclovir treatment. So first we are using Ganciclovir or Valganciclovir. If it is not responding, then we are using the Cidofovir. Again similar, the Acyclovir resistant mucocutaneous herpes simplex in immunosuppression patients, topically on anogenital warts. Anogenital warts is also caused by the different types of the herpes virus, mainly the herpes simplex virus type 2. Primary toxicity is dose related kidney damage. So nephrotoxicity may be there, gastric disturbance, some constitutional symptom, hypersensitivity, neutropenia, uveitis, etc. can happen, but the most common adverse effect is the nephrotoxicity. So you can see this is the viral particles. So these are the different Epstein-Barr virus, different types of the herpes virus that enters within the cells, DNA replication happens, mRNA synthesis happens, and ultimately their multiplication and replication happens. So these are the different types of the drugs, newer drugs that mainly acts. This Cidofovir, the newer drug is the Brin Cidofovir, which mainly inhibits the DNA polymerase directly. Okay. This Tecovirimat, this is a newer drug which basically inhibits the wrapping complex, wrapping of the virion particles, so that it can be released likewise. So Tecovirimat, this is a newer drugs. So these are the drugs that mainly acts at the different other areas of the virion particles, like wrapping, morphogenesis, etc. So in the different areas, there are different clinical trials are also going on for the different drugs, so that it can target in different areas of this. Okay. Like Foscarnet. Foscarnet is another drug which is a simple straight chain phosphonate unrelated to any nucleic acid precursor which inhibits viral DNA polymerase and reverse transcriptase. So again this is another drug that can block the herpes virus infection. It is active against the herpes simplex which are resistant to this cytomegalovirus, herpes group virus, and it is also active against the HIV/AIDS. When you will read about the antiretroviral drug, you will also encounter the name of the Foscarnet. So Foscarnet is effective against the herpes virus, it is effective against the HIV/AIDS also. Fomivitsen. Fomivitsen is a newer drug. Basically, it is an antisense oligonucleotide which binds the mRNA of the cytomegalovirus and interferes with transcription of early peptides in viral replication. So this is known as the antisense oligonucleotide therapy. This is a newer therapy. Again, it targets, just remember the name Fomivitsen, and it acts as an antisense oligonucleotide. Basically, this is used again in case of the cytomegalovirus infection, which are resistant to Ganciclovir, which are resistant to Cidofovir, and which are resistant to foscarnet. So, if it is resistant to all of previous ones, then we can use the antisense nucleotide therapy like the Fomivitsen. Okay. Usually for cytomegalovirus resistant keratitis, it has been injected weekly to monthly into the vitreous humor. So, intravitreal injection is usually given for this keratitis, cytomegalovirus keratitis. Ocular complications are common because it is a very toxic drug. So, you can see this is an antisense nucleotide therapy. So, there are, these are the different names. There are different newer and newer drugs are getting incorporated. These are all antisense nucleotide therapy. So, ultimately they cause ultimately activation of the RNAs or steric hindrance or splicing modulation or activation of the small interference RNA. siRNA means small interference RNA. So, these are the names like Fomivitsen, already you have seen. These are the newer ones like Inotersen, Mipomersen, Volanesorsen. Newer drugs, very costly drugs. Mainly all these are used in very resistant cases. No approved drug here till now, but the clinical trial is going on. Here for the splicing modulation, there is Etiplisen, Goloditsen, Vitalersen. So these are different types of the Marsens like Milasen, Nusinersen, etc. And for the small interference, RNA interference, they mainly causes the RNA degradation of the RNA itself. Example is Patisiran, Inclisiran, Lumisiran, Givosiran. These are the different types of the monoclonal antibodies also. So these are the different newer drugs, newer and newer therapies. These are all of the antisense nucleotide therapy. Mainly it is used in resistant cytomegalovirus infection because it is very prevalent now in case of the immunocompromised persons, some cytomegalovirus infections that will not respond to previous ones. So we need newer and newer antisense nucleotide therapies like Fomivitsen and their congeners. Okay. Next, coming to the anti-influenza therapy. So until now we have discussed anti-herpes virus therapy. Anti-herpes virus means herpes virus 1, 2, varicella zoster virus, and also the cytomegalovirus. That is quite separate. The treatment is somewhat different. Now coming to the anti-influenza virus. So influenza, already I have said, that causes episodic pandemic, episodic epidemic, and ultimately that causes many morbidity and mortality. Amantadine and rimantadine, this was the first anti-influenza therapy, but it is less used nowadays. Amantadine is a unique tricyclic amine unrelated to any nucleic acid precursor, but it inhibits the replication of the influenza A virus. Both amantadine and rimantadine are mainly active against the influenza A virus. They do not have any activity against the influenza B virus. This is the first one. So influenza B is not affected. H5N1 like avian influenza or bird flu, and H1N1 like swan flu, strains of the influenza A are resistant. So most of the influenza virus that are active nowadays are resistant to the amantadine. It appears to act at an early step, possibly uncoating, as well as a late step like viral assembly in viral replication. So they act at the uncoating as well as the viral assembly. Where it acts, mainly it acts in the M2 ion channels. So M2 ion channels is basically a proton ion channel that is needed for the viral uncoating and assembly. So they basically interfered with these M2 ion channels. Okay. So at one of the targets of the action. So resistance to amantadine usually develops due to the mutation in these M2 ion channels. So the anti-influenza therapy, first we are talking about the M2 ion channel interference. M2 ion channel, which is a proton channel which is needed for the uncoating and assembly of the influenza viruses. Mainly it is active against the influenza A virus. So you can see this is the influenza virus. It attaches with the host cells. After the attachment, it causes the internalization and uncoating of the viruses. Amantadine usually disables this M2 protein here. So this M2 protein is needed for this uncoating and assembly. So they basically disables the M2 protein, which is an ion channel basically. So prevents viral uncoating. So viruses rendered inert. So virus multiply, it becomes inert. So ultimately, if there is no amantadine, there will be internalization and uncoating and replication of the viral RNA happens. So viral clumping also happens and budding virion. So some of this comes outside and ultimately it propagates. So there are other types of the inhibitor. We will read about this, which is the neuraminidase inhibitor, which mainly acts here. So basically this neuraminidase inhibitor, another type of the anti-influenza virus, they basically inhibits the release of the virions and promote clamping. So basically there are two types of the anti-influenza therapy. One is M2 ion channel inhibitor, another one is the neuraminidase inhibitor. M2 ion channel inhibitor mainly disables the M2 ion protein, which is a proton channel which is needed for the viral uncoating. And another is the neuraminidase. This neuraminidase is mainly needed for the release and clumping of the virion particles so that it can be propagated. So neuraminidase inhibitor basically blocks here. Okay. So amantadine is generally well tolerated. Nausea, anorexia, insomnia, etc. can happen. Rarely hallucination and ankle edema can also happen. It is useful in prophylaxis of the influenza A2. Now it is needed mainly in case of the prophylaxis so that it will not happen. If some persons will go to some areas which is epidemic in the influenza. So during an epidemic or seasonal influenza, especially in high risk patients, influenza seasons and generally last for 2 months, we can use this. Treatment of the influenza illness, modest therapeutic effect, usually it is used last if it is not responding to the other types of the therapy. Parkinsonism, already you have seen that it is one of the anti-Parkinsonian therapy, but again in case of the Parkinsonism also amantadine is used last. There are newer therapies that is usually used. Contraindication is epilepsy, other CNS disease, gastric ulcer, pregnancy, etc. Rimantadine is a methyl derivative of the amantadine. Ultimately the potency is more, longer acting and better tolerated. So more or less the action of the rimantadine is similar to that of the amantadine, but it is more tolerated. Incidence of the side effect is lower, oral bioavailability is higher, mainly metabolized by the hydroxylation. It is similar, the doses, how it is acts, it is mechanism of action, all are similar to this. Amantadine resistant virus is also resistant to the rimantadine. So this is the problem. So you can see the same thing. So ion channel blockers, amantadine and rimantadine, basically they are blocking the ion channel that is needed for the uncoating of the virus particle. So genome replication will not happen, RNA DNA synthesis will not happen, protein synthesis will not happen. Assembly and maturation, here the neuraminidase inhibitor acts. Okay, so here it acts, amantadine and rimantadine. Next, coming to the Oseltamivir. So Oseltamivir is a newer anti-influenza virus drug which is a sialic acid analog with broad spectrum activity covering the influenza A. Amantadine resistance strains are also sensitive to this. H5N1, that is the bird flu, H1N1 swine flu, as well as the influenza B. That is in broad range of the influenza viruses usually are responding to the Oseltamivir. Usually it is very commonly used nowadays. It is an ester product that is rapidly and nearly completely hydrolyzed during absorption in intestine and liver, and oral bioavailability you can see approximately 80%. That's why it is usually used as a oral drug. Usually 75 milligram twice daily dosing is needed for 7 to 10 days. Okay. And for prophylaxis it is usually used once daily dosing for 7 to 10 days. It acts by inhibiting influenza virus neuraminidase, what we have already discussed. So basically neuraminidase is another enzyme that is needed for the viral clamping and the budding and release of the virion particles. So here the neuraminidase enzyme is acts. This neuraminidase inhibitor is the Oseltamivir, Zanamivir, etc. So this is needed for the release of the progeny virions from the infected cells and spread of the virus in the body's dust check. So when we are using this, also the propagation of the influenza virus, it is very contaminating ones. So it is also decreased. So the patient is also healed and patient will not transmit the disease to another one also when you are using the neuraminidase inhibitor like Oseltamivir. Okay. So you can see this is the normal viral multiplication where the virion comes, internalization and uncoding occurs, viral multiplication and viral budding and release of the virus happens. So when we are using the Oseltamivir, Oseltamivir is hydrolyzed by the hepatic esterases. So we are using is oral drug. So oral drug, it comes to the liver. So within the liver there are hepatic esterase. This hepatic esterase metabolize this Oseltamivir. So Oseltamivir become active. This is known as the active Oseltamivir carboxylate. Oseltamivir carboxylate is formed within the liver when we are ingesting in orally. This Oseltamivir carboxylate, this attaches with these virion particles. So when this is attaches with the virion particles, so internalization, uncoding and release, all these are blocked because they are basically competing with the neuraminidase and neuraminidase inhibitors happens. So ultimately it is inability to release the progeny virions and the viral load is decreased. So it is clear how the neuraminidase inhibitor like Oseltamivir acts. So within the liver it becomes active as carboxylate, it attaches with the virion particles and ultimately competes with the neuraminidase, and this neuraminidase is needed for the budding, clumping and release of the virion particles which are all blocked. So resistance can develop if there is mutation in this viral neuraminidase enzyme. Simple. In many areas now Oseltamivir resistant H1N1 is also prevalent, have been encountered. Though swine flu like H1N1 is still most sensitive. Indicated both for the prophylaxis as well as the treatment of the influenza A, swine flu, bird flu and influenza B infection. It is usually started at the onset of the symptoms. It is the most effective drug. Remember, reduces the severity, duration and complication, all three. Severity of the disease, duration of the disease and complication of the disease. All these are diminished if we are using Oseltamivir. Prophylactic use for 5 to 10 days prevents illness in contacts of the influenza patients. That is, in the same household, one person have some influenza virus infection. We can give the Oseltamivir prophylactically to decrease the viral load. Side effects, there may be some nausea, abdominal pain, there may be some headache, weakness, diarrhea, etc. But the side effect profile is very less. Zanamivir is another influenza A and influenza B virus neuraminidase inhibitor which is also effective in different types of the resistance strains also. It is administered by inhalation. So Zanamivir is a drug which is given by inhalational route. Okay. Like that of the anti-asthma medications, anti-COPD medications, it is given by inhalational route as a powder due to very low oral bioavailability. Small amount is absorbed after inhalation by the kidney with a half-life is 2 to 5 hours. Mechanism of action, its efficacy, all are more or less similar to the Oseltamivir. Some variant strains which are resistant to the Oseltamivir, they remain sensitive to the Zanamivir. Okay. It is used as an alternative to the Oseltamivir. Prophylactic use 7 to 10 days in the household contacts. But the problem is, since it is used by the inhalational route, so they can induce bronchospasm in those who have some history of the asthma or COPD. So there may be some bronchospasm that may happen. Zanamivir, similar, there are newer ones like Peramivir. Peramivir again, the same thing. So infecting influenza virus, you can see this is the Peramivir which is basically interfered with the neuraminidase glucoprotein enzyme. So new virus particles will be not released. So reduce viral replication and spread. So ultimately all this acts by the neuraminidase inhibitor. So there are very numerous newer Oseltamivir analogs are now being developed so that the toxicity is less, it becomes more targeted. Okay. So this is Peramivir. So you can see there are different other drugs that acts in the different areas of the influenza like Uabin, Arbidol. So this basically acts at the same level of the Amantadine in the fusion areas. Ribavirin, Favipiravir, mainly this blocks the different types of the transcription of the RNA. Neuraminidase inhibitors already we have discussed about it, decrease the release. There are nitazoxanide, antibiotics can also be useful, that decreases the assembly. Some newer drugs are also getting in trial, so that can act under different levels like adhesion, endocytosis, fusion, RNP formation, assembly, etc. Because this influenza virus is continuously getting mutated. Newer and newer bird flu, newer and newer avian influenza, swine flu is coming, that is not responding to previous ones. That's why newer and newer drugs are needed. So this is all about the anti-herpes virus drug and anti-influenza drug. So of this, the most important is the Acyclovir. Acyclovir, that is needed in different types of the herpes infection. Then the important question is, what are the drugs that is needed for the Cytomegalovirus infections? And the next one important is the different types of the anti-influenza drugs. The main two types of the anti-M2 protein and M2 channel and anti-neuraminidase. Apart from this, there are some newer drugs are also there. In the next class, we will discuss about the different types of the drugs that are active against the hepatitis B, hepatitis C, different other viral infections. Thank you.